Sagar. He is an assistant professor of emergency medicine and anesthesiology at Emory. His primary clinical focus is adult critical care in the CVICU at Emory, with additional time in adult emergency medicine at Grady Memorial Hospital. He's also a primary member of the ECMO team, leading consultation, cannulation, and initiation of local and remote VV and VA ECMO. And right now he serves as the Director of Operations for the Emory ECMO program and Associate Medical Director of the CVICU. So please join me in welcoming Dr. Dave. And whenever you're ready, Dr. Dave, you can go ahead and introduce yourself and share your screen.
Awesome. Thanks, Angel. Let me share my screen now. Can you guys see this okay? Awesome. Good evening, everyone. My name is Sagar. I'll be presenting a talk titled ECMO and Pulmonary Embolism, Bridging Intervention to Saving Lives. A little bit more about me. I was born and raised in New Jersey. My background is residency training in emergency medicine. I went on to do a fellowship in surgical critical care at University of Maryland. Currently, as mentioned before, split my time with emergency medicine at Grady Memorial Hospital, which is the level 1 trauma center here in Atlanta, as well as in the CVICU as an intensivist at Emory University Hospital. I hold a couple leadership roles in both the ECMO program as well as the ICU, and I have no financial disclosures, but a bit of a disclaimer. I believe ECMO can save the world. And I think hopefully by the end of this talk, not only will everyone here get a sense of what ECMO is, how to use in pulmonary embolism along with the other therapies, but also believe this as well. So pulmonary embolism. Pulmonary embolism was first described by Nicholas Tulp in 1628. During his work, Tulp made observations in cadaver and autopsy studies of blood clots that were seen in the lungs. He did not have any focus in the clinical picture of pulmonary embolism, but this is the first description that we know of pulmonary embolism. Later on in 1819, René Laennec was credited with first providing the clinical description of pulmonary embolism, describing symptoms such as sudden shortness of breath, chest pain, and linked these to blockages in pulmonary circulation. Rudolf Virchow, who we know through the Virchow's triad of stasis of blood flow, endothelial injury, and hypercoagulability, described the conditions that led to thrombosis and ultimately laid the framework of prevention, identification, and treatment for pulmonary embolism. Pulmonary embolism is quite a widespread disease, affects 650,000 cases a year with 100,000 to 180,000 deaths per year. There's a spectrum of disease where patients can arrive alive and well, and it's almost thought to be incidental. Where, on the other hand, they can show up in complete cardiac arrest. Right ventricular dysfunctions noted in 20 to 30% of patients, and the disease process of chronic thromboembolic pulmonary hypertension, where patients have long-standing pulmonary hypertension and RV dysfunction, is noted in up to 4% of cases. Depending on presentation, mortality can range. Patients who are asymptomatic carry a less than 1% chance of mortality, though this continues to get higher and higher depending on the presentation. 2% with normal blood pressure, 8% with RV dysfunction, and then when shock is a presentation, the mortality jumps. 15% with hypotension, 25% with cardiogenic shock, and up to 65% when the patients arrive in cardiac arrest. The most recent and I think widely accepted classification for pulmonary embolism and risk stratification comes from the European Society of Cardiology. Here, patients are categorized based on low, intermediate, and high, with high being a presentation of hemodynamic instability. Previously, this was also termed massive PE. Intermediate, where a patient presents with RV dysfunction. This is separated further into high and low risk. This was the ARDS previously known as submassive PE, and then low risk, where patients may have clinical symptoms, but not anything to severity. As you notice, none of the risk stratification here talks about location and size of clot. There are multiple studies in particularly in radiology literature, that have determined that location, size of clot does not always indicate the clinical status of the patient. Part of this has to do with the blockage only being a portion of the disease process, which leads to the third highest cardiac death. Um, when a clot forms, you have an increase in RV afterload. This then causes RV dilation, tricuspid valve insufficiency, which increases RV wall tension. This then leads to myocardial inflammation, an increase in oxygen demand at the myocardium, which then can further lead to RV ischemia. Then you have reduced RV contractility, reduced RV output, a decrease in left ventricular preload now because the RV output's reduced. Cardiac output persists, coronary perfusion gets worse, and the patients develop the circle of death that you see in pulmonary embolism from obstructive shock. Removing the clot doesn't always solve the problem because this pulmonary hypertension can persist, particularly when the PA systolic pressure acutely rises above 50 millimeters per mercury. Current therapy, specifically medical therapies, use anticoagulation as a mainstay of therapy. Heparin, which was discovered in 1916, is the basis for most acute treatments. It was confirmed for its use specifically in pulmonary embolism in 1939. Along with heparin, vitamin K antagonists such as warfarin or DOACs, which are direct oral anticoagulants, antithrombin coagulants, are efficacious and likely safe in this disease process as well. Tissue plasminogen is recommended for high-risk PE. When evaluating, though, tissue plasminogen to anticoagulation, depending on the patient's presentation, they can have similar results when presenting with high-risk PE. The MOPPET trial looked specifically at half-dose versus full-dose TPA, found that mortality was probably equal between both. Pulmonary hypertension was probably equal between both. Major bleeding and intracranial hemorrhage was reduced in the half-dose population, while hemodynamic decompensation was about the same. Ongoing currently is the PITO trials. These looked at TPA versus no TPA. They may have helped hemodynamics, but intracranial hemorrhage may have also been higher in half-dose compared to no dose for TPA. PITO 1's complete. PITO 3 is currently ongoing. Other therapies include procedural therapy. So surgical embolectomy is a much older therapy that specifically has to do with open cardiac surgery, placing the patient on cardiopulmonary bypass, and then removing the acute clot. Catheter-based therapy, however, has become more and more prevalent, especially as of late. And though the interventions can be more efficacious at times than medical management, they can carry a higher risk profile that's on par with surgical embolectomy. Catheter-based interventions have a non-zero risk, with citing around 4 to 10% for bleeding risk. Now, catheter-based therapies are also a bit of a spectrum, which we'll go through right now. This catheter-based intervention is specifically about having thrombolytics. This actually originates from initial therapy. Talked about injection of tissue plasminogen. TPA was initially given through Swan-Ganz catheters, which we don't see very often except outside the ICU I work in, which is the cardiac ICU. When the Swan is placed into the PA, previously TPA was injected through the Swan with the idea being that TPA would specifically go towards clot. This didn't exactly work because the flow path of least resistance. And so TPA went pretty much everywhere else except the clot, going to the distal pulmonary arteries and then developing pulmonary hemorrhage. The catheter-based interventions now specifically use ultrasonographic technology to emit TPA into a specific spot where the clot is and have that TPA go distal even past the clot. Seattle trials were single-arm studies comparing catheter-based interventions and found that it could be done safely with improvement in RV failure. Mostly they included normotensive patients. Seattle 2 showing a significant improvement in RV function within the first 24 hours. However, in the Seattle 3 trials found that compared to systemic lytics, maybe this has the similar risk profile, and there was no ultimate change in 90-day mortality. Ultima was comparing specifically catheter-based interventions to medical therapy, similarly found improvement in RV function, but no difference at 90-day mortality. The Canary study, which specifically looked at catheter-directed thrombolytics, was stopped early due to no change in outcomes, which for them was specifically earlier mortality, and was stopped early due to futility. Now, the extract PE study, this looked at suction catheter devices. Here showed an improvement in short-term outcomes, but this was not studied to show long-term outcomes. The FLAME study showed significant success, particularly in patients who came in with high-risk PE when compared to conventional therapies such as anticoagulation and TPA. Here, they used the FlowTriever device, which was mechanical thrombectomy. There are multiple current studies going on right now, which range from how the high PETHOS study, which is comparing catheter thrombolytics and anticoagulation versus anticoagulation alone. Peerless, which looks at mechanical thrombectomy versus catheter-directed thrombolytics. PE tract, which is catheter-directed thrombolytics versus anticoagulation alone. And STRIKE, which is suction thrombectomy looking at long-term RV dysfunction. The primary outcome for studies are not specifically looking at differences in long-term mortality, but primarily more so in RV dysfunction in the short term, but again, not particularly in that long term. The reason that has to do with exactly the physiology that occurs with pulmonary embolism, and that kind of comes back to what the physiology of death is for these patients in terms of changing mortality. So thinking about the physiology of death, I think about the 1-9 science course I took in freshman year of college, which was microeconomics, and this is supply and demand. Physiology of death at a cellular level, we develop an oxygen deficit. This oxygen deficit is initially fully recoverable. And we actually do this all the time when we exercise past our limit, when we see athletes on TV doing high amounts of anaerobic activity. However, when this oxygen deficit persists, you then develop irreversible cellular injury, which then leads to tissue dysfunction, multi-system organ failure, and then eventually death. The equation of life here talks about delivery of oxygen, and this really does sum up what our treatments are aimed at in all of medicine. You have a patient who comes in with cardiogenic shock secondary to myocardial ischemia. The patient goes on inotropes and to increase their cardiac output to increase delivery of oxygen. The trauma patient comes in with multiple gunshot wounds to the abdomen with a bleeding liver. You start massive transfusion protocol, use whole blood, and try to do damage control resuscitation and surgically stop the bleeding. Your patient comes in with flu or superimposed bacterial pneumonia, and they're hypoxic with the diffuse amount of parenchymal disease. That poor oxygenation you try to reverse by intubating them and using mechanical ventilation. That is exactly talks about how PE reduces cardiac output and leads to a reduction in oxygen delivery. Pulmonary embolism causes a acute increase in pulmonary vascular resistance. This RV pressure overload then leads to an increase in RV wall tension, RV dysfunction, reduces LV preload, systemic arterial perfusion, overall causing this cycle of RV ischemia, RV dysfunction, and round it goes. This is where ECMO can help a patient. And so what ECMO stands for is corporeal membrane oxygenation. So what this is something outside the body. It's an artificial barrier that provides oxygenation. The way ECMO works is you have a cannula in place that takes blood, that sits in a vein that takes blood out of the body. The blood's then shot through a pump and then flowed through an oxygenator with sweep gas flow that runs concurrently. This is where oxygenation and CO2 removal occurs. The blood is then brought back in through inflow cannula or return cannula. This cannula can sit in a vein or it can sit in an artery. ECMO started initially back in 1885 with the first prototype of cardiopulmonary bypass. The early uses of the prototype failed due to poor perfusion, stroke, and ischemia. Then, similar to PE, in 1916, the discovery of heparin caused a resurgence in cardiopulmonary bypass. Successful trials in canines produced this new technology known as the iron heart. John Gibbon, who had a fellowship specifically in cardiopulmonary bypass, perfected the circuit, created a freestanding roller pump device for extracorporeal support. It was the size of the piano, and it was the first prototype of ECMO that was used successfully in 1953 when he performed open heart surgery to repair an atrial septal defect. The first successful use of ECMO outside the operating room dates back to 1971 in Santa Carla, California. Dr. Hill successfully treated a 24-year-old patient after a motorcycle collision. This device next to the patient that looks like half a keg is actually the oxygenator. It lasted about 6, maybe 12 hours before it had to be completely changed. Below Dr. Hill's patient is baby Esperanza, who suffered a meconium aspiration. Dr. Bartlett, who's considered the father of modern ECMO, placed her on ECMO for respiratory support. Next to the picture of her as a baby is her at the age of 20. To give some context of what the ECMO circuit looks like compared to some other technology, this is what the first video game looked like, also out in 1971, called Computer Space. Both technologies have changed drastically since they first came out. The rise of ECMO for respiratory failure was marked by Caesar and Eolia trials, and they were two landmark trials that not only showed a pivotal role for VV ECMO, but marked a rise of ECMO use in ECMO centers, particularly in the adult patient population. ECMO then has extended out to cardiac arrest, both inside and outside the hospital, with impressive outcomes now moving towards more prospective control trials. Over the past few years, we've seen an increase in ECMO use. Similar to cardiopulmonary bypass, ECMO initially saw struggles with poor perfusion, bleeding, and stroke. But advancements in technology, sophistication, management, and refinement and selection criteria has brought about the increased use of ECMO, and now we're in that era trying to find its home. Two broad types of ECMO, we have VV ECMO and VA ECMO. Primarily, VV ECMO is used for respiratory failure, and VA ECMO is used for cardiac support. VV ECMO, you think of towards the end spectrum of respiratory disease. So a patient comes in with some shortness of breath. Before they even arrive to the emergency department, they're probably on a couple liters of nasal cannula oxygen. As they continue to have persistent respiratory failure, trial of non-invasive positive pressure ventilation. So this is going to be your Airvo, heated high flow nasal cannula, BiPAP. When that fails, move on to invasive mechanical ventilation. The patient gets intubated, but started on a low to moderate PEEP strategy. That doesn't work. They go to a higher PEEP strategy. That doesn't work. Now you're talking about paralytics. Now prone positioning. High frequency oscillation still used in some centers. But when you have refractory respiratory failure, that's where ECMO comes into the realm for primary respiratory failure. Primary cardiac failure is more VA ECMO, and this is primarily where use is more seen for pulmonary embolism. So these are patients where you are having biventricular failure, which is what the disease process is in patients with acute pulmonary embolism, where VA ECMO can provide both cardiac and pulmonary support. When thinking about putting someone on VA ECMO, I think about preparing to take off a flight. Identify your destinations, make sure the patient is clear to board, and then find your exit rows once you've arrived on the airplane. So some undesirable locations, or what I can call the New Jersey of locations. From there, so I think that's allowed. Persistent shock. Person goes on VA ECMO for something like bleeding, or something like sepsis, or something like profound burns or anaphylaxis. These are disease processes where vasogenic shock, vasoplegic shock, hypovolemic shock, or hemorrhage is the primary driving force of disease there, where providing cardiopulmonary support doesn't help the patient. Patient gets on ECMO as a major complication, has one of those issues such as stroke, such as bleeding or limb ischemia. This not only leads to death, but can also lead to a major comorbidity and a reduction in quality of life. Or the patient's stable on ECMO, but is unable to wean from ECMO support and has no other alternative therapies. Some desirable locations are myocardial recovery. That's what we hope for every patient who goes on ECMO. Or the patient gets bridged to a transplant, or the patient gets bridged to a durable LVAD. Now, some destinations, a little bit about those last two destinations, is that they generally need to have a patient who has good social support, abstains from substance abuse, and is able to display adherence to medications and follow-up. For an LVAD, they should be able to tolerate anticoagulation, have a dilated and large left ventricle, and then adequate right ventricular function. That last one gets blurred sometimes, but that's generally where the destination therapy for LVAD can be. In terms of heart transplant, generally this is an age less than 70, a BMI less than 35, and no other severe end organ dysfunction, excluding dual organ transplants, such as heart, lung, heart, kidney, heart, liver. Then check this boarding pass. Is the patient a candidate for VA ECMO? So some major contraindications include elevated age, severe neurologic impairment, end-stage systemic disease, such as end-stage liver disease, the inability to receive blood products, as the patient is going to be prone to bleeding when on VA ECMO, irreversible illness, or a prior moribund condition, such as moderate to severe dementia or severe physical debility. So checking the boarding pass, check to see is there a major contraindication. If there is, consider avoiding ECMO. If there's not, weigh the potential for good myocardial recovery or a candidate for LVAD or heart transplant. If both of those are no, then again, consider avoiding ECMO. Now, once you put the patient on ECMO, maybe you don't know all these things, but then you find out, start thinking about where your exit rows are. Can you bridge the patient to recovery? Can you bridge to LVAD? Bridge to a heart transplant? Consider comfort measures only? Or is the patient on a bridge to nowhere? The time frame for these is what I generally put here, understanding that every day that the patient's on ECMO, you have an increase in those same risks that they saw in the early days of cardiopulmonary bypass: stroke, bleeding, ischemia, and then adding to that things like infection. Now, if getting onto a plane is VA ECMO, then eCPR or ECMO during cardiac arrest or with cardiopulmonary resuscitation is highway to the danger zone. When considering ECMO in these patients, think about what's going on with the patient. Do they have an acute reversible refractory cardiopulmonary insult? Nobody wakes up in the morning, takes their dose of metoprolol, misses their dose of ECMO, and then dies. There is an insult that is driving their cardiopulmonary arrest. And if it is something that is acute, reversible, and refractory to other therapies, consider ECMO, knowing that the time frame to making that decision is much shorter than the other patients that I'm mentioning. Now, a bit about the steps in cannulation. It starts with modified cell ginger technique. The reason I say modified is this is not the patient where you want to get vascular access through and through and then bring the needle back. Here, you want to get as close as you can to 12 o'clock access when looking at cross-sectional view and make sure that you're not back wall to the patient or to the side wall for the patient. So I'll talk a bit about why as we go through. Once you get percutaneous access, a wire is placed to get purchased into the vessel, then place a micropuncture sheath. Reason I like to use this is it can be a bit more forgiving if you hit into the vessel but then come back out in terms of causing bleeding. Then once the wire is passed through the micropuncture sheath, a serial dilation until placing the cannula. Big advocate for using bedside ultrasound or point of care ultrasound. And this is also supported by national organizations, mostly as ECMO began as an open procedure and then found that some of the contraindications, such as high BMI, were no longer seen when adapting to percutaneous access. Confirmation of the wire can be seen right at the vessel, or as I have here on the right of the screen, as you get closer to the IVC by the atrial junction. Wire confirmation can also occur using fluoroscopy or bedside X-ray, as seen here, and then placement of the cannula can also be used at the same time using the same devices. Percutaneous dilation is step by step, and then once the tract is dilated and the cannula is placed, then the circuit connection initiation. A few things about connection is that we use a wet connection to avoid any air. Initially attach loosely to verify that there's no air, then tighten. Inform the team when you're about to go on ECMO, as the patient's going to receive about a half liter of saline, which can be warmed or can be colder than room temperature. As this hits the heart, you can develop things such as hypotension, arrhythmias, and even cardiac arrest. So making sure the team knows, is aware, and is able to resuscitate, and then slowly initiate flows and increase flows, expecting some transient hypotension. A bit more in peripheral VA ECMO is that along with a venous drainage or outflow cannula, arterial return and inflow cannula, you can also have a distal perfusion catheter. The techniques of this are to provide access and flow to the SFA as the cannula itself sits in the CFA or the common femoral artery. Here to allow perfusion down to the limb. Consider, if you're performing the procedure, a little bit of the difference in sizes. What I have here is the difference in arterial and venous catheters that we typically use. So an arterial line is generally 18 gauge. It can range from 16 gauge to 20 gauge catheter. It's about 1.3 millimeters compared to an ECMO cannula, which is typically 20 French, again, ranging anywhere from 14 French up to 23 French, depending on the center. Quite larger an arterial, an A line that gets placed. Similar when comparing venous cannulas to central lines. Central lines are typically going to be 7 French compared to the 25 French, again, also ranging from 21 to 29 French as your single stage, as a drainage cannula. It's important to respect these steps in cannulation I mentioned because things can go wrong as you get into these larger cannulas, particularly when placing it. Here's a picture of a complication, and in here, whether access was directly at 12 o'clock, whether the catheter was backwalled, whether the wire was lost, whether it was dilation wasn't done with care, it's unclear. We know it's the patient suffered a complication, and imagine this happening after putting a large hole in the artery. Along with ECMO complications, if you're doing this in cardiac arrest, consider the associated other complications that can happen with CPR, ranging from hematologic to non-hematologic complications as well. And when talking about experience in cannulation, for all those who are training or those different levels, everyone goes through this. It's the Dunning-Kruger effect. And I've been on the top of Mount Stupid. And this is where do a couple of these procedures and you start to feel great. You wonder why people worry about these complications. Then you have one. And speaking as someone who's had every complication you can imagine with ECMO cannulations, you then quickly lose your confidence. But as experience comes and you respect every one of those steps and learn the differences, you become an expert. So talking specifically about how VA ECMO helps in pulmonary embolism, it breaks this cycle. What VA ECMO does is it helps decrease the RV pressure overload by diverting blood away from the right ventricle. And then by providing that retrograde flow with peripheral VA ECMO, you increase systemic arterial perfusion, therefore maintaining coronary perfusion. This is one of the first studies that looked at ECMO and pulmonary embolism, included 21 patients, 19 of which were VA and 2 were VV. 62% survival for massive PE, suggesting an algorithm that put VA ECMO after the patients developed cardiac arrest. For those who had anticoagulation and TPA before decompensation, survival in the study was 45%. For patients who had primarily ECMO support up front before decompensation, there was an 80% survival rate. This was specifically looking at using VA ECMO early in massive PE. Here was 20 patients where survival was 95% with a 0% RV dysfunction at the time of discharge. When comparing further VA ECMO to surgical embolectomy, the time for being the patient onto bypass and unloading the RV was 4 hours compared to 11.5 hours, favoring VA ECMO. VA ECMO also had better neurologic outcomes. Comparing VA ECMO to, in terms of neurologic outcomes were better, not only with surgical thrombectomy, but with earlier VA ECMO considerations. In this group of submassive or intermediate risk, BOVA scoring can help tease out some patients that will have a higher mortality, to the point where if patients are already developing signs of RV dysfunction that will impact their mortality, consider VA ECMO for this as well. Now, this does not have any guidance in terms of studies specifically looking at VA ECMO for intermediate risk. But at least in my practice, when patients have these high risk intermediate PEs, where you're already seeing RV dysfunction, instead of waiting for them to decompensate, we'll get them up into our CVIC with micropunctures and watch them, or put them on ECMO sooner, particularly if they're showing signs of cellular ischemia, such as elevated lactate. Ultimately, we have a lack of randomized controlled trials and prospective studies for these things. And when considering some of the literature, I do think about one of these this article from the British Medical Journal, which talked about the lack of randomized controlled trials in using a parachute when jumping out of an airplane. Sometimes we don't have all the evidence to use an intervention, so we use our understanding of physiology to get the information. Most non-funded studies on high-risk PE had patients that were either already on ECMO, with the PERT consortium recommending using ECMO to assist with high-risk catheter-based interventions. Here is our multidisciplinary algorithm when using ECMO, primarily having early consults for ECMO in patients who have high-risk pulmonary embolism or in that intermediate risk with signs that are high risk or elevations in lactate. Meanwhile, the low risk as well as the intermediate and high risk still all get a PERT team consult, which is from our interventional team that primarily does our catheter-based interventions. Where to cannulate is a large range. At our center, we provide remote cannulations where the have become so mobile that they can come to bedside and perform safely by a trained team that utilizes point of care ultrasound or dynamic fluoroscopy. Transporting these patients as well. I have a few pictures here showing both flight as well as transport, and that in the center picture, that center blue device, that's the ECMO circuit itself, which has become quite portable. Post-ECMO management primarily surrounds resting the patient's right ventricle and optimizing their neurologic status, and then either repeating their CTA as well as repeating their echo to evaluate RV dysfunction. If on systemic anticoagulation, the patient's RV is improved and the neurologic status is well, is what you hope, and the clot burden has improved and the clinical status is better, the patient can get decannulated. If not, then consider other interventions such as surgical embolectomy. Catheter-based intervention, I think, is finding a home sooner in this in trying to relieve the clot burden to allow for less time that it would take for the RV to recover function. A bit about CT imaging and VA ECMO. VA ECMO provides retrograde arterial flow. So timing in your CT imaging can be quite skewed. I have a couple pictures here for a patient that I cannulated for VA ECMO in the setting of cardiac arrest for pulmonary embolism. CTA was performed, the patient was still quite ill, so ECMO flows remain, and contrast was timed as it was for any other study. As you can see, some of the images here are quite concerning for a dissection. Particularly, a retrograde dissection is a real risk for patients with VA ECMO, which is even more elevated when you're getting chest compressions and emergently cannulating. What's strange about this is the dissection was seen proximal to the takeoff of the left subclavian, not retrograde, which did prompt us to make sure we got another study. And the reason this happened was the retrograde flow was mixing with the antegrade flow from the heart. And you can see in this cross-sectional image the difference between the two flow patterns meeting at the proximal aortic arch. So some phased imaging specifically that we use is having arterial phase followed by a second arterial and venous phase, utilizing a protocol at our hospital where for VV ECMO, central VV ECMO, and RVAT, contrast is used as it is for any other patient. But when you get to patients who on VA ECMO, particularly also central VA and VAV, then here the ECMO flows are reduced down to about 1 liter to 1.5 liters. These patients are accompanied by a nurse as well as a ICU provider to provide resuscitation and perform all these various scans with multiple timings to get the optimal imaging for the patient. Along with CTA imaging and repeat echo function, it's also management for these patients also depend a bit on what is happening with their native cardiac flow. And one of the dangers we run into is north-south syndrome or LV distension. Both can occur on peripheral VA ECMO and both present with pulmonary infiltrates and worsening pulmonary compliance. In north-south syndrome, also known as differential hypoxia, here is where the patient has pulmonary infiltrates and poor compliance. Patient has worsened lung function, but it gets recovering cardiac function. Here, the native cardiac output takes deoxygenated blood and ejects it out of the left ventricle and can induce hypoxia specifically up the right upper extremity and the right carotid, which is the most proximal portion of the aorta. Ways to combat this can be to focus on improving lung function, remove things that increase native cardiac function, such as ionotropy, increase ECMO flows, or ultimately transition the patient to VV ECMO or VAV ECMO, which is placing another cannula on the right side of the heart for a return of oxygenated blood. LV distension, on the other hand, also presents with a worsening chest X-ray, with a worsening lung compliance, But here, it's the opposite problem. The patient's cardiac function is so bad that their left ventricular and diastolic pressure increases as you have retrograde ECMO flows from essentially uninhibited retrograde flow. This then leads to increased left atrial pressure, pulmonary edema, pulmonary hemorrhage. Instead of seeing upper extremity hypoxia, you see hyperoxia, where the mixing cloud of blood flow is moved so proximal, it is actually at the opening of the aortic valve. A few ways to improve this is either increasing inotropy, decreasing ECMO flows, or venting the left ventricle with a couple different strategies. Impella is one, atrial septostomy, or an intra-aortic balloon pump in that level of efficacy. And along with along with watching out for these specific instances for LV function, whether it's improving or not, is a few other things in terms of balancing the patient's preload, afterload, LV function with either inotropy or LV venting. Mind you, these patients don't need to necessarily be hooked up to the ventilator, sedated, and paralyzed. These patients can continue to be awake, continue to function as they have support of their cardiopulmonary support, even to the point where they can be ambulating, which you can see here. It's a patient completely awake, patient who had suffered cardiac arrest, which we suspect, of course, we got a CTA after they were stabilized from pulmonary embolism, who's continued to ambulate and walk. And we ultimately did bridge him to recovery. Lastly, when I say ECMO can save the world, these are the worlds I'm talking about. These are the different, maybe not the world is getting saved the way the Avengers did in New York, but more so that their families, their friends, their livelihood gets saved once they can come back from the brink of cardiopulmonary failure with that's been refractory to treatment, and ECMO can get them back to their worlds. Important to know that ECMO can't be done alone. It takes an entire team. It takes everyone from identifying the patients to placing the cannulas to management to the nursing care, the respiratory therapy team, the nutritionist, the pharmacist, the management of these patients after decannulation and getting them through that post-ECMO phase. That's about all I have for this evening. Take some questions.
Hi, I have a question.
Yeah.
I'm a first-year medical student, so it might be a silly question. First of all, thank you for the presentation. I was definitely captivated by all of the mentions of Avengers and Avatar and heroes. So I really appreciate that. I was wondering, for the ECMO circuit, are you concerned about developing thrombosis within the circuit, or is there sufficient anticoagulation? How do you combat the ECMO itself causing further thrombosis complications for the patient?
It's a great question. It's one that has gotten better over time since ECMO's first use, but something that we go over daily. And so you're completely correct. As soon as blood touches something that's not its own, the shear forces it can induce thrombosis as well as procoagulable states. Coagulable states. So bleeding as well as thrombosis becomes an issue. So a few things we do to combat this is we do get daily labs. So the specific lab that we get quite frequently is a plasma-free hemoglobin. Other labs you can also get are LDH, bilirubin, haptoglobin, and then we, on the other side, trend anticoagulation very, very carefully as well. Now, the way the circuits have now been constructed and the way the oxygenators have formed in terms of blood flow through them, thrombosis has gotten much better to the point where for patients with VV ECMO, so these are cannula side of the body, we will sometimes run without anticoagulation, whether that's because they are at high bleeding risks due to other disease processes such as trauma, or because they inherently have a high concern for bleeding. We will run them without anticoagulation. For VA ECMO, this gets much more dicey because you're getting returned directly arterially and your risk of clot going and causing stroke is very, very high. So for these patients, we do anticoagulate them pretty much, all the time, except for incredibly rare circumstances, using things such as heparin, bivalirudin, or argatroban. Additionally, we have perfusionist and ECMO specialists. ECMO specialists being nurses or respiratory therapists who their specific job is to manage the circuit, checking to see if there's clot formation, as well as different pressures that we get on the ECMO circuit itself that can tell us that, hey, clot's forming, or there is an increase in pressure before you get there's an increase in difference of pressure from going into the oxygenator and out of the oxygenator, or signs that, hey, as we increase rotations per minute, the blood flow is not increasing at all, then that can signal a clot in the circuitry itself. Absolutely. We'll go on to the next slide here. To me, pictures help a lot, so let me pull up a picture. Here we go. Okay, so for VA ECMO here, you have drainage from this cannula, which is sitting in the vein. Typically, we place this either at the inferior cavaitral junction or the superior cavaitral junction so that we can get bicaval drainage and completely drain the right atrium to reduce flow from the right ventricle into the pulmonary artery. That blood's then taken, goes through the pump, goes through the artificial membrane oxygenate or artificial membrane lung, however you want to call it, and then comes back in through this through the common femoral artery into the iliacs and flows blood retrograde. This capture of blood from here and increase in blood from here runs at about 5 to 6 liters, which in terms of cardiac output is pretty good, especially if the left ventricle is weak and you're reducing its preload draining out of the right atrium. So then this blood gets shot up through past the renal arteries, past the celiac, through the descending aortic arch up into the ascending arch. And so this blood up to here, and some of the technical studies, specifically these are ex vivo studies, show that about 4 to 4.5 liters of blood flow in a patient whose LV is diseased and in cardiogenic shock will get you flow up to the coronary vessels. And so typically you can run these circuits without running into a lot of shear forces, again, depending on the size of your cannulas, up to 4.5 to 5 liters.
Okay, so because there's such a big pressure difference, you don't have to worry so much about like things preferentially going into anterograde. Things will also go retrograde to like the heart and brain equally.
You hope so. So I say that because that is what you're describing is the exact fear that comes up with differential hypoxia or Harlequin syndrome or North-South syndrome. So the image I have for that is here. So here you have blood that's coming out from here, getting returned through here, but the LV function has recovered, the left atrial function is recovered, the right ventricular function is recovered, but the lungs are diseased. So the blood that's injecting from here is deoxygenated, but is pushing that quote unquote mixing cloud further down and can even go well past the left subclavian. To monitor this, we get right radial A lines or right upper extremity arterial lines and use that to monitor oxygenation, at the very least having a pulse ox on the right hand. And a way to mitigate this, at least using the extracorporeal circuit, is actually placing another cannula into the right internal jugular vein. This then allows for oxygenated blood to not only travel retrograde, but then also enter through the right atrium so that anything that's going into the right ventricle, ultimately into the left ventricle, is oxygenated blood.
Thank you so much for re-explaining.
Absolutely.
Hey, Dr. Dave. Quick
Hey,
question
how's it
for you,
going?
since we're on that North-South syndrome. My name is Armand, fourth-year med student at Rush. So it's almost paradoxical in that you eventually want there to be increased cardiac index, but that's what's also leading to the upper extremity hypoxia. So my question is, are you frequently measuring the patient's cardiac index, and how are you doing that? And then what's your transition point for a sufficient enough cardiac index for taking the patient eventually off VA ECMO?
It's a good question. So the way to check and like truly measure technically with a pulmonary artery catheter is using the cardiac index you get from thermodilution and adding that to the cardiac output that you're receiving from the ECMO circuit. The reason being is what you're seeing on the pulmonary artery catheter is going to be what exactly escapes the right atrium into the right ventricle, then ultimately through the pulmonary artery, and then to the left ventricle, while the rest of the cardiac output is getting drained through the ECMO circuit. We don't necessarily look for a cardiac index, like a specific number, or a specific amount of cardiac output. What we specifically look for is what happens when you use ECMO support. So in patients that are recovering from cardiogenic shock, one of the things we'll look for is native pulsatility, but then also what happens to the patient's perfusion as we reduce ECMO flows. Now, because of the risk of clot, typically do not with full anticoagulation past 2.5 liters of ECMO flow. But then after that, we'll do something called a ramp trial or a turn down trial or what have you, where during TTE, we'll come down on ECMO flow for short periods of time and get measurements of sonographically of what's happening with the heart. If that looks favorable in terms of filling pressures through the PA catheter, in terms of fusion, in terms of echographic findings, then we'll go at our center to the operating room. Here we'll have TEE guidance for these patients, and then come down on ECMO flow. And then as we're getting ready to do the cut down to remove and repair the arterial cannula site, see what happens additionally, echocardiographically, systemic perfusion wise, and within that 10 to 15 mark of being off the ECMO, coming off ECMO support. Now, during that time, let's say we find that the left ventricle looks pretty good, but the patient's right ventricle is still pretty diseased. We can try other things such as RP ECMO or VP ECMO, which is a catheter, a cannula that drains from the right atrium and returns through the pulmonary artery. You don't get the same risks of having an arterial cannula, but you still provide some right ventricular support. So it's not specifically a number like cardiac index or specific cardiac output, but it's more so how that changes coupled with echocardiographic findings with reducing VA ECMO support. Now, to date, there is no standardized way or standardized recommendation on what specific values you should look for on echo, which exact findings you should measure first. But that's something our center is working on. And maybe if you come here for residency and then ultimately, obviously, a critical care fellowship, that's something you can help with us here. In terms of paradoxical improvement in cardiac output, just remember with North-South syndrome, Harlequin syndrome, differential hypoxia, whatever you want to call it, the lungs still have to be bad. So that's one thing that I will see people get a little bit worked up on. They'll say, okay, well, look, the patient looks like they have recovering cardiac function. We should really, really be worried about their right upper extremity, maybe even put them on VAV early. The lungs have to be bad. So if the lungs aren't bad, then you don't necessarily have to jump to that. Now, if you're seeing hypoxic results without evidence of pulmonary disease, then you should think about something else, such as maybe you have membrane oxygenator failure. Maybe the blood that you're giving back to the patient is going through an oxygenator that's filled with clots. And I've seen configurations change when really it's the circuit that needs to be changed for that reason.
Yeah, thank you so much for that answer. I guess like on the opposite side of that, like for the patients with LV distension, how are you guys approaching, like I heard you say that you might place like an Impella catheter or like use inotropes, but like how would you be approaching like placing that Impella device if you have such large cannulas in the FA?
Okay, it's a good question. In terms of the clinical management for it, it really depends on the disease process. So for example, someone who has pulmonary embolism, they conceptually should recover their LV function pretty quickly after anticoagulation and ECMO support. In fact, what we'll focus on then after they're on ECMO is specifically trying to get them to catheter-based intervention. So we'll give some time. Now, if we're seeing LV dysfunction clinically for these patients, we'll hold off on putting an Impella. Conversely, if you have someone with non-ischemic cardiomyopathy that you're bridging to an LVAD, they're probably not going to recover their LV function magically after you put them on ECMO because they've got long-standing disease. Those patients will look a little bit sooner to put them with an Impella support. Now, the technical aspects of doing it, these cannulas, though, are large on the arterial side, is still a short catheter. Typically does not cross over the common femoral artery to the point where I have a case report out there that showed contralateral limb ischemia because the cannula was too long and too big for a patient. Typically, the cannula, we want it to be short because of Pascal's law in terms of short cannula providing least resistance for flow. And so the contralateral leg is where access is done and used to put in the CP impella, or what we'll jump to pretty early on is going to a 5-5 impella via axillary artery. Reason being is just the degree of hemolysis and the positionality of the CP impella.
Thank you so much.
Absolutely.
If anyone else has questions, they can drop them in the chat. Otherwise, thank you so much, Dr. DeVay. This was a really awesome talk, and we all learned a ton.
Absolutely. Well, thanks for having me. Really appreciate it. Feel free to shoot me a message if there's another question or if there's anything I can help with. Good luck to you all.
Definitely. Thank you.
Thanks. Take care.